So my name is Dr. Sarah Coll. I'm an orthopaedic surgeon based in Cairns in far north Queensland. I'm the current president of the magnificent Australian Federation of Medical Women, and it is my wonderful privilege to invite Dr. Didio to speak to us this evening on a topic of his choosing. I greatly admire a lot of the work that he does, so I'll be very keen to hear from him about anything he wants to tell us. So I hope the ladies enjoy this. Take it away.
Well, thank you so much, Sarah. It's an incredible honour to be here. Thank you. I wanted to open with obviously an acknowledgement of the traditional custodians of the lands upon which we all sit and stand this evening. Here it's the Ngunnawal and Ngambri people, and I want to acknowledge the traditional owners of the lands upon which every person watching this grants us a safe passage. I also wanted to shamelessly take advantage of your kind invitation to talk about not one but two topics of my choosing. Firstly, the regulatory framework in Australia, which does have some very important gender-based quirks to it. And secondly, about doctors' health and well-being. Please shut me up whenever you wish. I plan to go for 10 or 15 minutes or so. Firstly, in terms of the regulatory framework, my current roles are local family GP, volunteer on the Doctors for Doctors state panel, which I serve on with my colleague Marjorie here, and I'm on the national board of that as well. And my day job most days per week is being the director of the Professional Services Review, the PSR. PSR is a part of the Australian regulatory framework, which has quite a broad spectrum. Again, I defer to my colleague Marjorie, who was both the chair of the determining authority of the PSR as well as a long-standing and highly regarded deputy director and chair of multiple committees. Regulation is a vitally important part of a service, whether it's law or accounting or medicine, or any profession that you can think of that chooses to maintain the integrity of its practice through highly articulated and peer-based standards and measurement and review of practitioners who may or may not be outliers of some kind against those standards by and for their peers. This is an essential part of a safe and stable system. Most regulation occurs in Australia across AHPRA and the medical boards. There's a medical board in each state and a national board. And AHPRA is a registering authority that receives complaints, notifications as they call them, about medical practitioners. They review about 17 different craft groups, doctors, physios, chiropractors, you name it, and register them. And they also accept notifications about them. Last year, they received about 6,500 notifications about health practitioners, mostly doctors. And so depending on how you measure clinical practice, participation, and percentage of reviews, roughly 6% of Australian doctors got a notification to AHPRA and the boards last year. Representative groups, such as the committee that I've shared with Sarah, make representations to AHPRA every year about improving the practitioner experience. And moving from those groups into this role, I've made it I guess, one of my passions is to improve the experience of all people going through a regulatory experience, because we know from the exit interviews that practitioners undergo that for most people who experience a regulatory framework experience, like being reported to APRA or the board or to PSR or to Medicare, it is a 9 out of 10, and it is the equal of the most stressful experience of their lives. And it most certainly should not be, but unfortunately it is, partly because of the way we see ourselves and the way we define ourselves and our identity and our happiness by our profession. It's one of the things that keeps us safe and healthy and enjoy our jobs more than so many other professions, but it's also one of our great weaknesses in that we feel deeply hurt, ashamed when we go through regulation, even though the vast majority of regulatory experiences are unbelievably private and confidential. Other parts of the regulatory framework in Australia is that Medicare reviews about 1,000 practitioners every year, and it refers about 100 of those practitioners each year to the PSR. This is about 50% of that comes from a review of data, and about 50% of it comes from whistleblowing or people making anonymous or non-anonymous reports to Medicare about the billing of a particular practitioner. For example, someone might send an anonymous email to Medicare saying that Dr. Coll charged me or Medicare thousands of dollars for a hip replacement, but all she did was prescribe me an antibiotic. That's, I think, a made-up example, but we'll just leave that as is for now, Sarah. And thank you and everybody else for practicing so ethically and speaking of it so publicly. The data part about that is important to look at as well. People get quite anxious about the data part. They say that, well, you know, I've been working really, really hard, so does that mean I'm going to trigger a review with Medicare? And in general, it does not. And Medicare has an awful lot of data and information that it receives, and it makes decisions about who to review based upon its own criteria, which I'm not privy to. The only thing that I know is that 100% of all referrals to our agency, PSR, come from Medicare. When you get referred to PSR, roughly 10% of all referrals, and remembering that these referrals have been through the Medicare process, roughly 10% of all referrals get dismissed under what's called a Section 91, and about 20% of referrals get referred to a committee of peers. So in the case of a urologist, there'll be 2 urologists on a committee, and the committee chair will be an experienced chairperson like Marjorie or in a past life, myself. And the balance, about 70% of people, get what's called a Section 92 agreement. And that's an agreement between the director and the practitioner of a set of terms based upon the director's opinion about whether inappropriate practice has occurred or not. At PSR, we've tried to do 2 key things in the last couple of years that I've been in the acting and now substantive role. The first is to build upon the values that we have of fairness, transparency, and professionalism. We have a staff of about 40 plus people at any given time, and about 200 consultants from all around Australia in every possible craft group and profession. And we've also tried through a variety of measures to improve as much as possible the respect and dignity that is afforded to every single practitioner who appears before us. We've also tried to extend that to every other regulator. And so about 18 months ago, we formed a group along with all the other key regulators, DVA, Comcare, APRA, the medical boards, about 12 people or agencies, and get the head of all those agencies to meet every few months and discuss first and foremost the way that practitioners experience the regulation that they undergo, and trying to maximise their safety, and their privacy and their experience as they travel through what is inevitably a very challenging process. One of the real wins, I suppose, that AHPRA experienced last year that they were very, very proud of was that in my regular meetings with them, they described a practitioner who had undergone a review in 2023, and the same practitioner had undergone a review a year or two earlier. And that practitioner said that the outcome was very similar. The issue was very similar, but the process could not have been more different. They were treated with so much more dignity and respect. They were listened to and attended to. And it was very much something that AHPRA and the boards were proud of. At PSR, we often see people who have difficulty in accepting that they may not have done the right thing. But more often we see people who are good, decent, kind practitioners who have engaged in inappropriate practice in a very small part of their practice completely accidentally. And so, sure, it may be inappropriate practice, but it's engaged in by a highly decent and ethical human being who has probably caused themselves far more critique and suffering than would ever be imposed on them by an external regulatory agency. The important thing for us is to ensure that, I guess, under an Act of Parliament, our job is to protect the Commonwealth from paying for inappropriate healthcare and to protect the community from receiving inappropriate healthcare and the potential consequences of that. I've used that expression a lot, and that's because it's how it's embedded in what we do, inappropriate practice. And people ask, well, what is the definition of that? The definition of inappropriate practice is what the general body of your peers would consider to be unacceptable in their practice. It's not a low bar, but it's a reasonable bar. It doesn't mean that practice has to be perfect. It doesn't mean that it has to be completely correct in every way so that it would pass a viva. It is what the general body of people on a typical day in a typical member of your craft group would consider to be okay and reasonable. And that is very, very important to us. We have, in the last couple of years, particularly focused on making sure that the outcomes that we get are incredibly fair and reasonable, and that we listen to absolutely everything that a person under review has to say to us in their submissions, whether they be written or verbal, whether they're at a committee or at a meeting process. We strive very much to have a multi-stage process where fairness is paramount. There's an enormous amount of anxiety among the profession in the 35 years that I've been in it and the 30 years that the PSR has existed about how regulators looking over your shoulder and adding to the burden of the stress and anxiety that is involved in being a doctor in Australia today. And although, as I said at the start, Sarah, that regulation is vitally important, it needs to be done also in a way that's contextualised and welcomed by the profession. To that end, I have regular meetings with every single college, every major craft group, and anybody who will listen to my boring speeches, regardless of who they represent. And that's because, as any regulatory agency, I feel we need to be as accountable as possible to the people that we regulate. I'd welcome any questions on any of that before self-indulgently proceeding to the next topic.
I've got loads of questions, so ladies, feel free to either raise your hand or just butt in. Marjorie, did you want to ask a question or make a comment?
Oh, yes, with Antonio. There's an extra layer that Antonio hasn't mentioned, and that's after the cases come from Medicare, there are other peers, such as he and I, on occasion, going through the practitioner's notes. And even before it gets to a committee, there are peers looking at the notes of the person who's been reported from Medicare. And that's been an arduous task that Antonio used to do, I still do. And so there's a layer that dismisses or suggests that people may not need to go to committee before a committee. That be fair, Antonio?
Yes, that's correct. Only about a fifth of cases, maybe between any given year, about a fifth or a sixth of cases ever go to committee. That's correct.
I wonder if that will change if people start using AI to make their notes. I wonder if that's going to change the referral pattern.
That's a fantastic question. We've had our panel training in 2 cities so far and a third and final one this weekend. And keynote speakers on each of those occasions have been people discussing the extraordinary changes in AI. Sarah, one of the great lines that I enjoyed was a person in Sydney saying that, oh, this is old school AI. This is more than 9 months old. And a couple of your craft group colleagues in this town have started using AI, and one of them in particular was a bit put off by it and is going to have another crack, but has stopped it for now simply because it was just too good. And I said, what do you mean? And he said, and what he meant by it being too good was that he said something along the lines of, I said that there'd be side effects such as bleeding. And the AI wrote, I said that there'd be side effects such as bleeding and pain and DVT and a whole big long list of things. It is the Wild West out there, and you just don't know the quality that you're going to get. But he was distressed by the fact that the record that was produced was far superior to the service that he delivered.
Consultation.
Yeah. Now, obviously, that's not going to be a problem for some people. But you're absolutely right. What Marjorie and I have a lot of practice in over the last few years is when you review a record, you might see one that's absolutely first class. It's got a whole range of things in it. And then only when you review a second, third, fourth and fifth record from the same practitioner, you realise that they are absolutely identical in 6 lines here, 4 lines there, 4 lines there. In other words, the person has crafted some keystrokes.
Oh, macro.
Macros. Now, we in general practice use macros all the time. When you see 50 patients on the same morning to give them all a flu shot, macros are very, very helpful. But there's a certain amount of judiciousness required to decide whether a macro is indeed appropriate. And if a macro says respiratory rate 14, pulse rate 62, blood pressure 138 or whatever, and they're all the same, then that is a fairly obvious sign that there's been a lack of clinical input into a whole range of consultations. At other times, macros are incredibly useful and help you to form an excellent record. So with the AI, given that you can pretty much tell AI to do anything, it is going to be a really interesting space in the next couple of years as we see it bedded down and evolving. But it's no different, I feel, from the incredible anxiety and excitement and combination thereof that occurred when we got electronic health records, when we started using computers, all sorts of evolutionary experiences that we've all seen over the last few decades that eventually just became a normal part of healthy practice. And some people use it the wrong way, and the vast majority of practitioners use it the right way, because the vast majority of practitioners are highly ethical people doing the right thing, or at the very least trying hard to do the right thing. I think that when we are in this learning experience and we're getting the hang of it and we're doing things for the first time, we will, as always, err on the side of caution and kindness. It is a really great opportunity, not just for the profession to reflect on how to use new toys, but on regulators to reflect on how to make sure that we review the people using those new things in a really safe and respectful context. And by way of example, I suppose, if a person was to come to PSR and that person's medical records were manufactured through the use of AI, it would probably be inappropriate for that person's records to be reviewed by a person who knew nothing and had experienced nothing about the use of AI in their own records. It may well be the right thing, just depending on the people that are involved.
And I guess it just comes back to peer review being critical and potentially early peer review in the process, I think is what you're saying to us.
Not just that. I mean, that is absolutely right. But more than that, I think education beforehand is vitally important. We've talked with everyone, state and federal AMAs, colleges, particularly the RSCGP, other representative groups, ACRM and RDAA, about education of their members in relation to quality of medical records and not getting into trouble with regulators. We've got a significant influx of new practitioners entering the country over the next few years, which is not too much different to the last few years. But I feel that it's not just for the benefit of the professions and patients, it's incredibly protective of those individuals arriving to our shores that we give them some form of education in relation to appropriate billing and some fundamentals of appropriate communications and culturally sensitive communications in Australia, so that they've got some tools to protect them from accidental exposure to regulation.
I think there's a broader brush there. Go on.
2 or 3 further points. One, AI or electronic medical record is, whichever way it's done, is eminently better than going through handwritten notes.
Of course,
One.
yes.
2, Antonio didn't mention, and I always feel when I'm going through notes or on a committee, the complexity of Medicare. It's become an extremely complex beast now, and it's very hard for particularly the people that Antonio just alluded to, new arrivals in this country, to get grips of. And one thing we do in medical education is put MBS and PBS at the centre of early education of our registrars. And I think the third point I'd make is that Antonio is very good at saying everyone's wonderful, but there are some people who, have done the wrong thing. And PSR in recent years has actually put out in their newsletter items about such cases so that people can learn from them, so that other people can learn from them. Is that reasonable, Antonio?
Yes, indeed. We have for several years now published our monthly reports on our website. In the vast majority of cases, very much de-identified to protect the practitioner under review and their privacy, but they outline exemplars of the kind of things that we've done in the previous month, what findings were made, and they might say something like a general practitioner in Australia was reviewed and saw a lot of 721s and 723s. They were disqualified for 12 months from billing those items and had to repay X amount of dollars. That kind of thing. Or another practitioner was seen in relation to such and such, and the case was dismissed. So it's quite an educative process to look at the website and see the kind of things that we look at, so that people can be made aware of what it is in their own practice that they should be looking out for. Marjorie is also correct in that a small percentage of the practitioners that we see have quite deliberately engaged in inappropriate practice, and that is the way of the world.
Yeah, I was just reflecting on your comment that the MBS and the PBS education starts early in the registrar training, which of course is absolutely non-existent in our training, and it's a wild experience to discover, you know, the initial consultation item number. That was part of a long and arduous process trying to familiarize myself. So can you just briefly mention the 12 agencies, DVA, Comcare, APRA, medical boards that meet to discuss how did that come about? I like the way you put it as the maximising the safety and the privacy of the practitioner, but from an advocacy perspective, how did that actually come together? Like, how that sounds like such a good idea, and yet I could imagine that would have taken a lot of shoe leather.
I went through my contacts in my address book and texted everybody and said, let's get together and talk about what we do and share the things we have in common. And everybody was absolutely fantastic and said, yeah, what a great idea. And so we've met twice and we've got a third one coming up next month. And that's literally all it was. It's not a formal group. It's a loose association of colleagues, but I just find them all fantastic people who have very little in the way of judgmentalism and a great deal in a desire to make the world better. I mean, everybody's got a slightly different goal and perspective. So, for example, APRA and the board's perspective is very much the safety of the community. PSR's perspective is the protection of Medicare and protection of patients from inappropriate practice. Other agencies, everybody's got a slightly different perspective, but we have an enormous amount of common ground. And I really, really enjoy the opportunity to sort of raise some challenges and build some trust to improve that sort of landscape for the general person trying to practice medicine and get through it without accidentally getting into strife.
Okay, well, if everyone else doesn't want to raise their hand, are you happy to proceed with your next? Oh, here we go. Have you noticed? I've got a little question here. Have you noticed any? Oh, here we go. This is, of course, why we're here. Have you noticed any particular trends in case outcomes of inappropriate practice and at an aggregate level that are gender-based, for example, impacted by a gendered bias? Excellent question.
Yeah, look, yes and no. I mean, most of the stuff that we get is fairly consistent over the last couple of years. We've been getting 80-20 reviews back, which is practitioners who see more than 80 patients per day on more than 20 days per year. And we've got a 30-20 one as well, which is 30 or more telehealths on more than 20 days in a particular year. Shanna produced a magnificent module about 4 months ago now about some gender-based issues in practicing medicine, which I really, really enjoyed, about how, you know, chest pain is slower to diagnose in women than it is in men. And at PSR, we do see some general practice things that might have a gender base. More people, for example, do implant-on insertions and removals per percentage of doctors who are women than are male. There are some procedures and some consultation items that are more gender-based. Typically, I'm not surprising anybody. In Australia, it's roughly 4 level B item 23 consultations to every 1 level C item 36 consultation across the board. It's significantly different between female practitioners and male practitioners. Female practitioners do more long consultations. Surprise, surprise. In no way does that suggest that they are doing the wrong thing at all. It just means that they have, in a very, very broad and sort of generalised way, they have slightly different practices. And some female practitioners also do more sort of, I struggle to use the word caring because I think all practitioners are caring, but they make greater use of mental health item numbers in some states compared to others, and based upon gender. I don't think that inappropriate practice per se recognises colour or creed or gender, but I think that some female practitioners who do lots and exclusive caring type consultations will potentially have those statistics very much skewed. Now, if, for argument's sake, a female practitioner did nothing but counselling and all of her consultations were long consultations, she might appear before Medicare, and Medicare might contact her and say, well, what's the reason for this? And they would have a conversation, and Medicare would or would not be convinced that that was reasonable or not. I don't know, because 90% of the cases that Medicare review, they close themselves without sending to us. But I have seen examples of practitioners of any gender who have done a lot of long consultations, and then when someone like Marjorie or myself reviews those long consultations, they are perfectly reasonable. And so there is no further action taken in relation to those long consultations. I've seen that more than once.
Interesting.
So,
Mhm.
of course, there are some other things. It's not just what happens from women, it's also what happens to women. And a lot of the medicine that we review is medicine that is, very, very relevant to the medical practice and the medical care that women receive. And we see that too. I can't say much more about it other than that it's an incredibly relevant part about what we do.
Well, I'll let you push on then.
Well, the other thing I
don't
just
want
wanted
to
to mention, the other thing I wanted to mention with some brevity is that doctors, again, it's no secret, have had a pretty tough time in recent years, and the practice of medicine itself is unbelievably challenging, especially if you want to do it well, especially if you care about your patients. I've given a lot of talks recently on burnout in the Australian Public Service, and I started doing these talks at the ACT AMA with Marjorie and our friends there. And one of the things that seems to be protective against burnout and exhaustion and emotional, distress is if you don't give a damn. I think we are all at very high risk of it because we all care. And so I just wanted to, make a plug. The Every Doctor, Every Setting framework was established a couple of years ago by the Commonwealth Government. And an action plan has been developed. I want to send you, Sarah, in your role as president, some information as to how individual doctors and practices and organisations such as yours and anything of any size in between can sign up to express their interest and commitment to the safety and health and well-being of doctors everywhere. And that is really, really important. And I'm going to send it to you, and hopefully you will distribute it.
Yeah, we can distribute, of course.
The second part of that is that there are some great agencies around Australia that look after doctors either in an urgent 24/7 context or in a slow and ongoing context. For about 28 years now, I've seen a distressed doctor once a day in practice, and that is much less than so many other wonderful colleagues that I know who look after doctors all the time. Thank you, Brenda, for keeping me sane. Well, you're not doing a great job, but you're doing a good job of keeping me sane.
Thank you for your kind words, Antonio. Yeah, you're doing a great job in keeping yourself well. Yeah, and it's interesting how many doctors how many specialists don't have a GP. I'm finding that as I'm speaking to specialists that I'm going to for my own health, that they don't have their own GP and most of their colleagues don't, and they're still prescribing for themselves. And that really worries me.
Yeah, that's very, very true. I had a not unusual moment 9-10 months ago where I texted two men because, you know, if you're looking for stupidity, look no further than the nearest middle-aged man. I texted these two guys, and one of them I said, you need to see him because your inflammatory markers are terrible and your knuckles are swollen and you're in a lot of strife and you're going to get into trouble. And while you're seeing him, can you get him to see you because your HbA1c is terrible? And maybe once a year or so you could come and see me. And you know, I say it not with the slightest hyperbole. I once said to one of my dear friends, "You've got a GFR of 5. Do you think maybe I could check your blood pressure now?" And that makes me laugh, but it also makes me weep because it's so true. So we have been encouraging everyone to go out there and look after themselves. Steve Robson has been a magnificent AMA president, and one of the things that he's campaigned hard on is to try and get doctors to get their own GP. But I wanted everybody to know that there are plenty of agencies out there, not just our own, Doctors for Doctors, which has a phone number you can ring 24/7 in your own state, and you can choose whether you speak to a doctor straight away who will talk to you, or whether you want to speak to a counsellor, or whether in fact you'd like both. And that's fantastic. And the individual state services provide a wonderful service. But there are plenty of other services such as Hand in Hand and other doctors' support services that all collaborate and all try to do the same thing, which is look after doctors' health and wellbeing. And I guess I just wanted to make sure that everybody knew that if they're struggling, that it's only a phone call or a website away to get help. The other thing that I guess I wanted to very quickly mention is I spent a fair while over the years on the New South Wales ACT Medical Benevolent Association. And one thing that I have seen change that's very different to what it used to be. Over the last 5 years or so, Medical Benevolent is about social work and financial support. There are more people living in their cars and unable to pay their rent contacting us now than there ever have been. And there are doctors, but there are more doctors contacting us saying that they just don't have access to their funds, or they've lost all their confidence because their intimate partner is controlling and horrible and almost universally male. That's not something I saw 25 years ago at the Medical Benevolent Association, but it's happening now. I think it's a combination of more stories, more media, more in our fiction and non-fiction showing people this ghastly, previously invisible conduct, this coercive control conduct, and people becoming more aware of it and reporting it. I fear that it also may simply be happening more commonly. And I am no longer the least bit amazed that it happens to highly educated, intelligent, brilliant, amazing, independent women who are broken down by it. So I guess that's something that's real that I've noticed, and I'm delighted that MBA is able to support these women, but I'm deeply disappointed that the situation occurs at all. And I guess I'm pleased that more people are aware of it. If you go back 20 years, none of us believed that chronic fatigue was real. If you go back 10 years, most of us didn't know much about burnout. If you go back 75 years, we all thought people with dropsy were malingerers, and what the hell is diabetes? I would like a world in the next 10 years, or hopefully a lot quicker, where some horribly gender-based treatment of one group of people by another group of people is completely known about and called out and surgically excised from our society.
You mentioned that you had something else that you wanted to talk about. Do we still have time for you to indulge in that?
No, that was just the medical benevolent, which you've very kindly allowed me to
very
sneak in,
good.
Sarah.
No, I like that. That was very helpful because I often, well, no, I don't oftentimes read about on Facebook, you know, people who are clearly struggling, and it's always hard to know what to offer, and certainly in orthopedic surgery we see people who've had trauma, and it's good to have a broader kind of range of options to offer people rather than just Panadol and narcotics. Does anyone have a question? Because I've got some more to go, but you'll need to raise your hand if you want to ask them. Can we just talk about international medical graduates, because I feel like that's a bit of a hot spot in Australia at the moment. I think we're trying to solve the rural problem, and we've been talking about international medical graduates, and I guess I'm really interested. You can obviously speak about the MBS, but I know you're coming from a much broader perspective about that cultural competency, and there's a nuance in there, not just about billing, but in also in how we interact with patients and how we. I don't know that you can necessarily teach the MBS. I think it comes with so much a bias and cultural background that because it's been around so long, we've sort of grown up with it. I guess, can you maybe speak to how you try and get this Australian billing system across?
Yeah, well, it's no secret that the PSR does not have a formal role in education about billing, and nor should it, because billing evolves. On the other hand, I'm shameless in my begging and pleading of everybody else to educate their members in terms of billing. And I guess one of the analogies that you might think about is that you can drive a car very, very safely without being a professional racing car driver. And I think that people who come to Australia really should be supported and educated by whatever representative group they choose to join in terms of safely and appropriately and billing and feeling comfortable that when they've provided a service to a patient, that they know exactly what they should bill that patient. When I was a boy, my first experiences of Medicare billing were, to put it mildly, hit and miss. I worked for a fellow who was extremely honest and ethical, and he said, well, if you do this, you should bill a long consultation. If you do that and you're not sure, just bill a short one. And he was beautiful. And I worked at a different practice pretty early on where the attitude was the maximisation of income, and the fellow who introduced me on my first day said, we're here to help three people. We're here to make sure the patient's happy, that the doctor's happy, and the shareholders are happy. And I didn't know much about that third person, and I didn't think they were particularly relevant to how I chose to bill. So I feel that it would be very, very unfair for people to come here and not have some kind of exposure to that. But not just that, also some social and cultural mores as well. Australians are just like any other country. We have our quirks, and I think that you really, really need to understand the depth of the hurt that some people have experienced, so that you can realise what their particular sensitivities might be. My daughter taught in a school in Sydney recently where she got accidentally got somebody's pronouns wrong and got a chair thrown at her and was tiraded with profanities. Now, obviously, that's not the right thing for that child to have done. On the other hand, you've got to think about what that kid must have been through in order to have reacted in that way. And so medical practitioners coming into Australia who see and have far more deep and intimate conversations than a school teacher might have, really, really should be educated about all those particular sensitivities, which Australia is progressive enough to respect and not get into strife about that kind of basic thing.
It must be very challenging. I'm fascinated about the whistleblowing. So you say 50% of your referrals are whistleblowers, and yet the culture of medicine is to not whistleblow. You know, we've struggled.
Yeah. Let me clarify. Those are referrals to Medicare. Nothing. We don't know. We have absolutely no idea whether the referral coming to us initiated through data or through somebody getting dubbed in. That's the referrals that go to Medicare. And of course, we also don't know whether the person who reported a practitioner to Medicare was a medical practitioner themselves or was a patient. We have no visibility of any of those things. But as you can imagine, as you can imagine, even that has some really important privacy implications. And I guess you would say that it's a very good thing that we at PSR have no visibility or knowledge about those particular details, to add an extra layer of protection and privacy between agencies for the practitioner under review.
I guess I'm looking at it from the perspective of, I thought that medical practitioners had an issue with whistleblowing. I thought we weren't doing enough of it. And yet the implication here is that we must be doing some. So if we're doing it for MBS item numbers, then we must be doing it in other ways as well, which I guess it gives me hope. So I guess you don't have a feel for what proportion would be patient whistleblowing and what would be colleague whistleblowing, or I guess
no idea
it's
at all.
Anyone around you. Yeah. Interesting.
What I can tell you, and as a wonderful example of, you can get a statistic to tell you anything. There was a period a few years ago where the fastest growing group of practitioner reports to AHPRA were from other health practitioners, which sounded quite dramatic. But that number of people was unbelievably small. It may have doubled from 0.1% to 0.2%. That I don't know the exact statistic, but both sides of the argument were supported by one part of that statistic.
Okay. And then, all right, so can I keep going? The exit view interviews, was that from the PSR experience?
No, that was elsewhere. PSR doesn't do exit interviews for fairly obvious reasons, I think. But we do receive a significant amount of feedback from the legal representatives of the practitioners under review from time to time. And it is incredibly important to me that regardless of the decision that is made, that the practitioner feels that they've been listened to. And so whether it's that large number that get an interview with myself or the number that go to a committee, it's incredibly important that they feel that nobody has made a decision at all before looking at them, talking to them, viewing their evidence, and that whatever evidence they choose to give is listened to. Whether the regulator agrees with it or does not agree with it, at the very least they have engaged with it and given it the suitable weight and attention that it deserves. There is nothing more frustrating to someone who has been accused of something of not having their arguments listened to. It's probably a good time also to add that if you want your arguments listened to in the best and most efficient way is to get a legal representative. And that is, I just see that's been put in the chat. Well said, Marjorie. We sometimes hear arguments along the lines of, well, I haven't called my medical defence organisation because I haven't done anything wrong. Or I haven't called them because if I do call them, then it's an acknowledgement that I've done something wrong. These arguments are not correct, and it is, I think, to any person's advantage to get your money's worth for the premiums that you pay every year. And when you find yourself receiving a letter or communication, make sure that you do contact your medical defence organisation, because they've represented these cases hundreds and hundreds of times in some situations. And for most practitioners under review, it's the very first time they've ever seen it. I'd rather my appendix was removed by somebody who's done it more than once.
Of course. Yeah, so I guess I keep hearing you say treating them with dignity and respect and listening to them. I think that will take us a long way.
The other
and
thing,
then
Sarah, is
also
putting it into
go on.
that a real context. If you, I'm sure others in the room have done the same thing, but 5 or 6 times in the last year, to mentor some people who've been through the APRA process. It's really, really interesting. They just keep asking over and over again, when will the axe fall? When will it all fall apart? And it takes weeks and months for them to figure out that it's over, it's past. There are no restrictions, or the restrictions are going to be there for 3 months or 6 months or however long it is, and then they'll be removed. Nobody's going to find out about it because APRA's not going to tell anybody, I'm not going to tell anybody. And the most important thing that you want as an outcome for a person who goes through a process at PSR, in my view, is that they've learned from the experience. They're not going to make the mistake again, and they're going to have a very long, happy and healthy career for another 30 years to come. There's no sort of permanent scar or tattoo or anything like that. It's got a beginning, a middle and an end, and then it's over, and then you move on with your life and be a wonderful doctor.
And I also like the concept that we don't have to be perfect. We have to do what a typical doctor would consider reasonable. And I feel very reassured that I'm being judged by a peer and not in a way that is legalistic or corporatized or a government kind of mandate. It's a peer. I think that's very reassuring.
It's a bit of a problem for Brenda. I've seen her notes. They're not typical or basic. They're really, really good. So kind of an outlier there, Brenda.
Yeah, actually, it's really interesting talking about notes and electronic records and macros. The more macros, the more you think, this isn't actually really what happened. It's just ticking boxes. And I see that in some of my colleagues. I'd much rather something that's brief but original.
Yeah, a great example of that, a fantastic example of that, Brenda, is you can tell the doctor has just ticked every single box when they examine a patient and the patient's got a normal prostate and normal uterus. That you see that from time to time and you realise you've ticked all the boxes without reading them, haven't you?
It's so true. And also some of my younger colleagues and it's not wrong to say safety netted, but that's all they say. They don't say what they've actually advised them to do. And I think, really, I'd like to know that you told them to go to the hospital if it got worse, or to come back tomorrow, or whatever.
Is safety net a GP code for something?
Yeah, it's
What's
saying
that mean?
exactly what Brenda said. If you're prescribed an antibiotic, you say, let me know if you get any side effects. Or if the person's got a headache, you say, let me know, or go straight to hospital if it gets worse or you start vomiting. That kind of concept.
Ah, interesting.
There's a wonderful study done in the UK many years ago. Oh, it must be 25 years ago, where a bunch of people in an outpatient department said, call me back if you get chest pain or a sore ear or you start coning. And something like 90% of all the patients said, yeah, righto, and headed off. It was a fantastic demonstration of how you've got to make sure they understand what you say before they agree to it. Beautiful piece of work.
Yeah, we're human as patients and as doctors. So I've got my one eye on the time, and unfortunately we've already hit time. Is there any desperate last questions we have? Marjorie, did you want to say anything? Thank you for your comments.
This is certainly not desperate. And Antonio mentioned the every doctor, every setting, which I hope comes into all medical education ASAP. We did some work in RACGP in the last couple of years on that. But there is another layer, which I think is really important, that maybe we can tackle in another president's discussion, and that's about a better culture. And so many of Sarah's in this, but many of us are interested in really addressing the culture of medicine that has led to some of this anxiety and distress and worry about the necessary regulatory problems. If we actually had a culture that if we could improve the culture of medicine as time goes by, that's the layer upstream from where we're talking. You speak to that, Sarah, because you're with me on that, I think.
Oh, no, I want to hear what Dr. Didio has got to say.
Yeah, I think that's a point superbly made. I agree with it very much. I gave an awful big chunk of my personal health and well-being getting a review into the culture at ACT Health many years ago. And I feel that there's 100,000 people practicing medicine, and the only people we treat worse than each other is ourselves, whether it's through overt poor conduct or simply self-neglect, and allowing burnout and emotional exhaustion to give ourselves permission to be an absolute bugger to work with. I know it happened to me, and I'm still, I've seen it happen in other people as well. It's really, really hard. And one of the things that you find in the youngest and most junior people in our profession is the depersonalisation that comes from complete exhaustion, and the way that somehow lets them treat each other and their peers. The vast majority of people go into medicine being and staying very well-meaning humans. And I'm not going to shy away from that for a moment. But one of the best ways that we can improve culture is to do it at the highest possible level as well as the lowest level. The A Better Culture group is doing great work, and I support it very, very much. Best way we can do it, though, is to start off with kindness at the microscopic level to ourselves and to every other person that we work with.
Micro kindness. Can we finish on that? Thank
Coming
you
from
very
a
much.
micro heart.
Yeah. Thank you very much for your time this evening, and thank you everyone for coming. I really do appreciate those insights into this process. I'm sure every medical practitioner struggles with regulation and the process, and I'm very grateful that you can demonstrate such grace and humility overseeing that.